What does the DEA think makes a medical clinic a pill mill? Many physicians that treat pain and addiction may wonder what criteria the DEA believes to be indicative of a pill mill. The following is from a motion filed in federal court regarding the prosecution of a physician. The government claimed in the motion that pill mills have been found to have common characteristics, including some or all of the following. Clinics are cash only and do not accept medical insurance. Provide no variation in treatment by prescribing each patient the same or substantially similar narcotic or narcotics in the same or similar quantities. Prescribe a trinity of drugs, including a narcotic, benzodiazepine/depressant, combined with a non-controlled substance, such as an antibiotic or muscle relaxant. 4. They prescribe specific narcotics as requested by patients. 5. Provide little or no medical examination. 6. Possess no medical equipment or equipment that is not operational. 7. Serve a large number of patients per day. 8. Make no recommendations to patients for alternative therapy or X-rays and physical therapy. 9. Direct patients to fill prescriptions at certain pharmacies. 10. Have patients who travel from long distances for treatment and/or travel in groups to the clinic. 11. See majority of patients without an appointment. 12. Employ armed security guards. First, let's acknowledge that none of these are crimes, then look at each from a doctor's point of view. Cash. Many doctors choose to only accept cash so they don't have to employ the staff required for billing. More than half of psychiatrists are cash only, and many practices, especially concierge practices, were starting to go this way. And in the past, many addiction specialists were cash only because insurance would pay little or nothing for this treatment. However, cash is harder for the government to trace, and while it may not be illegal for a physician to take cash, they will absolutely target you for it and use it to imply to the jury that you are shady. Number 2, the rubber stamp. Establishing protocols and procedures for patient treatment is a recognized and usually smart way to establish care. This can help clinic providers and staff know where to start and to be able to recognize if something was off base. An addiction clinic, for instance, might decide that all patients should be started on Subutex 4 mg BID and adjusted in 1 week, as needed, down or up, and perhaps changed to Suboxone if tolerated. This would be reasonable, but according to Dr. DEA, it would also be evidence of criminal practice, a pill mill. I've even seen where someone has been accused of a conspiracy to create medical protocols. Number 3 was medical combinations. The DEA, with its extensive knowledge of medicine, has somehow determined that people with chronic pain should not also be afflicted by anxiety, muscle spasms, or apparently an infection. They are very confused about what the Holy Trinity was, both religiously and in regards to medication. The real Holy Trinity, given that name by drug users, was oxycodone, carisoprodol or Soma, and alprazolam, also called Xanax. A breakdown product of Soma enhances the activity of oxycodone, and that is why very few doctors still prescribe this combination, though it used to be used quite commonly. And some patients who have been on these for decades will still come in as legacy patients. What do you do with those? If you try to help those people readjust their medications to something safer, you must still prescribe them during that bring-down period, and that will immediately make you a target. Number 4, getting what they want. Most chronic pain patients know what worked well in the past and what they had a poor response or reaction to. This is not automatically drug-seeking behavior, at least not to the doctor, but it is to the DEA, because they are confusing what an ER doctor sees with what a primary care doctor sees. In the emergency room, if someone claims they have never been on medications before but knows the exact names of everything and the dosing, that can be a red flag. In a patient who's been treated for chronic pain for years, it is not. Number 5, physical examination. The longer a doctor practices, the more focused and shorter the exam usually gets, especially for primary care and ER doctors. Watching the patient walk in, sit, and start to speak gives an experienced physician a wealth of information. Now a pain specialist, establishing a diagnosis, will do an incredibly detailed physical examination, worthy of a physical medicine and rehabilitation doctor and neurologist working together. These are very helpful for the primary care doctor treating that patient. But what the PCP will not do is try to replicate that examination on every visit, or indeed any visit. If a patient comes in from an orthopedist with a diagnosis of a fractured arm, we don't take that limb from the cast and move it around to double-check everything just in case the ortho was stupid. Having access to accurate previous medical records prior to the physical examination reduces the need for this, and indeed the laws in some states say that a comprehensive examination or a comprehensive record review must be done. Other states say and. Make sure you know which it is in your state. And also understand that telemedicine, including during the COVID crisis, controlled medications, which means in this case, no physical exam at all is possible. So somehow it is criminal to perform an examination that the DEA doesn't think was adequate, while it's not criminal to do no physical exam at all. Number 6 was the medical equipment. I'm not sure what to make of this. Almost every physician prosecuted that I could find had working equipment. I guess if something breaks down, don't keep it in the office. Number 7, number of patients. Some medical boards came to the conclusion that a good doctor would see no more than 640 patients per month. They came to that figure assuming that a good doctor would see one patient every 15 minutes, so 4 per hour, 8 hours per day, 5 days a week, 4 weeks a month. That seems reasonable at first glance. But what if you have a nurse practitioner or a physician assistant or a counselor? These people might see the patient and provide extra care and a critical second look while the doctor closely reviews the record, as he's reevaluating the need for controlled medications. The patient might then come in to see the doctor for 5 minutes. Now you will go up to 960 patients per month, almost 1,000. Clearly outside the usual practice of medicine, and off you go to the big house. Number 8 was imaging and alternative therapies. Okay, a true pill mill almost always does not do these things, which is not why you should. You should do it because it's good medicine. Now, many chronic pain patients are going to come to you having been imaged so thoroughly you can see their future descendants in the scans. How much radiation and expense should you put them through so you can say that you ordered an image and not end up on the pill mill list? Number 9 is a single pharmacy. There are pharmacies that will still try to fill prescriptions for patients with chronic pain and anxiety, and those that don't. And there are medical boards that think that you need to send your patients to a single pharmacy to be able to track them. With modern prescription monitoring programs, this is usually no longer necessary. And understand that while your medical board might want you to do it, the DEA does not. Keep a list of pharmacies on hand and give it to your patients. Do not have an in-house pharmacy that prescribes controlled medications. Number 10, traveling. As fewer physicians are brave enough to treat pain or addiction now, patients must travel further to find one who does. That makes this criteria the gift that keeps on giving for the DEA. And as far as patients coming in groups, the doctor's not sitting out in the parking lot. How in the world would he know? I suppose you need to put in outside cameras and have someone sit and watch to make sure nobody pulls up in a van. Number 11, appointments. Patients may love coming in without an appointment, but apparently the DEA does not. And I also think it is not practical for chronic pain patients, though exceptions must be made for cancer or unexpected events. Get the records and a drug screen when a patient applies to be a patient. Do not accept them for continued care until you have reviewed these. Number 12 is armed guards. Again, this is somewhat arbitrary. There are neighborhoods where not having an armed guard is inviting disaster. And what about the doctors who have recently been killed by angry patients? I guess the government's advice hasn't changed since the 1950s. Duck and cover. So there you have it, the 12 criteria, straight from the horse's mouth, on what makes your practice a pill mill. But this may not be enough. At a recent trial, the jury was told that a clinic was a new breed of stealth pill mill, one that knowingly did not break any of these rules to appear legitimate, while secretly only treating legacy patients to keep them hooked on opiates. As ludicrous as this may sound to my fellow medical professionals, it worked. I wish you all the best and good luck.